slides and the recording of the webinar will be posted on the CIN website within about a week. You can see the website up on your screen. So if you're interested in getting the slides and hearing or sharing the webinar with anyone else, feel free to do so. If you have questions during the webinar, we save plenty of time for questions. So you can post your questions in the chat box, which is in the lower left-hand corner of your screen. If you have logistical questions, you can send them to the host. If you have a question for the speakers, you can send the questions to all participants, then everyone can see what sort of questions are being asked. So today's speaker, first we're going to hear from Dr. Robert Moore, who became the Chief Medical Officer of Partnership Health Plan in July of 2011 after serving as Medical Director of Community Health Clinic Olay in Napa for 13 years. Partnership is a well-respected Medi-Cal and Medicare managed care organization serving 480,000 members in 14 Northern California counties. His major professional interests are quality improvement, operational effectiveness, and delivery system transformation. He's a graduate of UCSF Medical School and the Columbia University School of Public Health. And he still sees patients one evening a week at Clinic Olay and cares for hospitalized Clinic Olay patients one weekend per month. And then we're going to hear from Petaluma Health Center. We're going to hear from Dr. Danielle Orn, who since medical school at Nova Southeastern University has been passionate about leveraging technology to improve health care for the underserved. After completing residency in family medicine, she went on to complete a master's in public health and a graduate certificate in biomedical informatics. As Chief Medical Informatics Officer at Petaluna Health Center and Redwood Community Health, Dr. Orn provides leadership for initiatives in clinical systems, health information technology, and quality improvement. And she speaks nationally on EHR implementation and optimization, transformation to patient-centered medical homes for community health centers, and practice-based quality improvement. And also from Petaluma Health Center, we'll hear from Luke Entrup, who's the Director of Wellness and Innovation there. He oversees the development of wellness cases, shared medical visits, community fitness classes, and employee wellness programs. He and Dr. Orm formed the organization's innovation team, which use human-centered design methods to solve persistent problems, improve health outcomes, and adopt new health technologies. Prior to joining the Petaluma Health Center, he worked on public health and wellness initiatives at San Diego State University, the New York State Department of Health AIDS Institute, Care International in Rwanda, and the National Network of Public Health Institutes. He holds a Master of Public Health and a Master of Social Work from Tulane University and a Bachelor of Arts in Contemplative Psychology from Naropa University. So with that, I'll hand it over to our first speaker, Dr. Moore from Partnership.
Thanks, Lori. Can you hear me okay?
Yes.
Perfect. Okay, great. And let's see if I can go to the next slide. Perfect. So thank you so much. I really appreciate the opportunity to talk a little bit about the role of the health plan in supporting advanced care planning and palliative care. As Lori mentioned, my roots are in the community health center world. Still see patients there, which is important to stay connected. And as a family doctor, I've taken care of many individuals on the patient side with problems and medical problems that relate to a need for advanced care planning. And so I was able to really draw upon that experience when I came to Partnership to look at this issue. But because not everyone is familiar with Partnership Health Plan, I just wanted to give a very brief overview of Partnership. Partnership's mission is to help our members and the communities we serve be healthy. We also have our strategic focus areas are quality, operational excellence, financial stewardship, and really the idea of the strategic focus area of quality and looking at not just our members but the communities we serve fits in well with an initiative that I'll be talking a little bit about around palliative care. We are a county-organized health system, so we're the only provider of Medi-Cal managed care in the 14 counties that you see there. Membership is 480,000. So technically, we're a commission of the state of California, and so it's a sort of a government, sort of quasi-government organization. And when I first came to partnership, we went through hospital rounds every week where we review the most complicated patients that are in the hospital in our region. And I was struck by the number of patients whose story was clearly consistent with never having discussed advanced care planning with their families or caregivers, individuals with prolonged ICU stays with little or no hope for any type of recovery, whose family had various unrealistic hopes about miracles occurring and so on. So it was and all the way to the point of at one point we had 2 patients in the hospital who were being restrained to be given dialysis. So there was a great need clearly out there, and looking at how to try to tackle that as a health plan, it became clear that we needed to have a multifaceted approach, and that led to a focus that we call Offering and Honoring Choices, and it's an initiative to improve advanced care planning and palliative care in the communities we serve. We have 4 major goals: to increase access to outpatient advanced care planning, to increase access to palliative care, to ensure communication of care preferences across the continuum, and then to facilitate community-wide culture change. If you do any one of these, it's not going to be as effective as working on all these together. We do have, within this area, let me go to the next slide. There's a quality case for advanced care planning, which is really related to, as you can tell from the stories I mentioned earlier, to patient autonomy, patient self-determination, and respect. That it is a poor quality care if individuals are receiving treatment that they have not had a chance to really give meaningful input on, just because that's the care that our system defaults to. So there's a strong quality case. There's also a business case for advanced care planning. One concrete article from JAMA in 2011 found that patients who had an advanced directive who died had approximately $5,500 less in hospital costs than patients who die without an advanced directive. That was a very concrete example. But more globally, advanced care planning and defining goals of treatment is a critical part of many different efforts to have more effective use of resources, whether it's through hospice, palliative care programs formally, case management programs. It's a critical business need as well. We'll talk more about that a little later. So we have 12 different projects, but I'm only going to showcase 4 of these in the brief time I have to give a sense of the types of projects that we're working on in this realm. And the first one overlaps a bit with what the speakers from Petaluma will be talking about, so we'll talk about that first. So the first project in our portfolio is a pay-for-performance incentive for having conversations about advanced care planning with patients who have advanced illness and reduced life expectancy. As part of this, it's required that there be a discussion of the advanced directive and, if appropriate, PULSed. It doesn't have to have those forms signed because we don't want to incentivize filling out forms when they're not ready to be filled out, but we want to incentivize the discussion. Then the attestation is submitted to partnership. We audit a subset of those to make sure that the conversations occur, and ultimately we pay a $100 quality bonus per attestation as a quality bonus with a maximum of 100 attestations per site. Now, we've actually had this particular pay-for-performance incentive in place for several years with fairly low usage. As you can see in the graphs at the bottom, that the use in 2012 and 13, which was fairly similar for many years. We talked a lot about the program, but in the end, for a variety of reasons, the use was rather low. In fact, the 2012-13 was a dip below what it was the year before. And we made a number of changes in the program in terms of simplifying the program, and then also we think that in the synchrony with all the other programs that we've been working on with advanced care planning is helping as well. When this was the only program that we were doing, when this was our only effort to improve advanced care planning, it was less effective than when it was promoted in conjunction with the other 11 projects that we're working on. So we think that had it. And you can see that this past fiscal year, we had 40 sites that submitted attestations, with over 1,300 attestations submitted. So we're really starting to see a big uptake in this, and we're very excited about that change. That's the first initiative, and again, you'll hear a little bit more on the Petaluma side about how they operationalize that on the frontline level. A second initiative at the health plan level is training care managers on advanced care planning. Why is this important? Well, care managers interface not just with the patients but their family, much more than many providers do in our face-to-face visits. The care managers have a longer time period than a 15-minute visit. They interact with patients and families at key junctures of their lives, and often, because advanced care planning is neglected by others in the healthcare system, it's a great opportunity to have individuals focus on this at the times that's most needed. And lastly, care managers often are very skilled at having challenging conversations, so they're well equipped to take the extra step and learn how to have this particularly difficult conversation. There's some research on integrating advanced care planning with care management. I listed them here. I'll tell you just some of the concrete results of those. For Aetna's project called Compassionate Care Program, starting in 2004, they published an article that showed that hospice use increased from 30 to 70%, and the length of stay in hospice increased by 14 days for getting in hospice earlier. Sutter's Advanced Illness Management Program, which started in 2009, they found a 50% reduction in hospital admissions in patients enrolled in this program, 75% less ICU days in enrollees, and over $4,000 in savings per patient over a 3-month period. Kaiser's Home-Based Palliative Care Program, they found increased patient satisfaction, decreased emergency department use, inpatient days, and physician visits. Sharpley-Steely's Transition Program found a 43% reduction in cost, a 50% reduction in inpatient admissions. And Healthcare Partners Case Management Program, they've not published information, but theirs focuses on renal failure and renal insufficiency and cancer, and they've also found cost savings. So there's a pretty strong evidence base for significant cost savings with advanced care planning that is conducted by case managers. Some key features of all of these programs are, there are 4 of them. The first is they focus on patients with advanced illness. Obviously, the business case is less strong if it's a general population. The second, case managers receive special training around the advanced directive, advanced care planning, and how to have the conversations. The third is the advanced care planning process is integrated with other case management needs by the case manager. And fourth, the conversations happen over time. It's not a one-time conversation. In Partnership Health Plan, we did a training about a year ago for our telephonic program, and we have a telephonic case management program. And so far, we've had advanced care planning status recorded on 268 individuals with complex medical problems, and it resulted in 61 individuals completing an advanced directive, and that's with a telephonic program. There is a training program being developed at Cal State University San Marcos Institute of Palliative Care. It's not yet up and running, but that's a place that will be available for this type of training. Third program that Partnership is involved with is Employee Awareness of Advanced Care Planning. The reason we believe in training employees is that if we are going to promote advanced care planning in our communities, it seemed like a good place to start was with our own staff so that they were all familiar with it and we were contributing to the community-wide change in culture. So I won't go through the details of how we set it up. It's a very interesting process. But the results were that we trained 95% of our staff. We doubled the rate of advanced directive in our employees from 13% to 26%. And of those that did not have an advanced directive, 66 planned to do so. And the really interesting finding is this multiplier effect. For every 1 employee we talked to, they talked to 2.5 members of their family. Usually they're older members of the family who are not employed, who are chronically ill, and they actually filled out a number of advanced directives in those family members. So it's a really good model to spread this through our communities. We do have a toolkit available. If anyone is interested, they can reach out to me, and I'd be happy to send that toolkit to them. The next, fourth effort is community coalitions. We were inspired by the work done with a group called Respecting Choices in La Crosse, Wisconsin, which starting in 1999 developed a program starting to work with the community to develop a community-wide standard for advanced care planning conversations. They standardize, the big steps that they work with is standardizing the advanced directive so that their whole community developed a standardized advanced directive. The second was training community facilitators, so not relying on doctors and nurses and the healthcare system to provide the education. Third was, and in terms of outcomes, they found at the end of their program being implemented, and over, of course, it took a while. It's a very complex program, but they reached the point where 95% of their patients admitted to the hospital in their county had an advanced directive on file. And that's the baseline. Just to give you a perspective, a baseline in our area is about 10%. So it's a big increase. And the net effect on costs is fascinating. The La Crosse, Wisconsin community is in one of the lowest, they're the lowest 10% of cost of care for any Medicare nationwide. So they've had a tremendous decrease in community-wide healthcare costs with this effort. Obviously, they're probably doing other work that's good as well, but this is certainly a part of that. They were featured in an article by the surgeon from New York, from Boston, who's written about the upstream problems, where they compared the ICU type of patients in La Crosse, Wisconsin versus in Boston, and it really showed a dramatic difference in the type of patients that they're providing intensive care to. This program is spread across the U.S. and internationally. A number of countries have adopted the model. And then locally in partnership efforts, in partnership counties, we have 2 counties that are working on this. In Napa Valley, Napa Valley Hospice is providing the leadership on a group called Honoring Choices Napa Valley. They licensed the name from the Wisconsin folks. And then in Sonoma County, they call their effort My Care, My Plan, Speak Up Sonoma County, to look at really that community coalition to promote advanced care planning in their community. So just one last heads up, there is, if you're really interested in this topic, we're co-sponsoring, partnerships co-sponsoring with Napa Valley Hospice, a conference, Advanced Care Planning Across the Continuum. The keynote speaker, Bud Hams, was the founder of the Respecting Choices program, and so that would be a very exciting opportunity to hear him speak, and that's November 6th and 7th in American Canyon. If you're interested in registering, you can click on the link there. And now I'm going to turn it back to Lori and over to the folks in Sonoma. This is a picture of what happened in the earthquake. This is the road to Sonoma from Napa. You can see there was almost a 1-foot shift. The Sonoma moved north by about a foot in the earthquake. And I'm going to turn it back to Lori, I think.
Yeah, great. Thanks, Bob. I think we'll hand it over now to Luke and Danielle to hear your presentation on Petaluma. And I will.
Great. Thank you very much. I'm going to go ahead and set this to our first slide. This is Danielle. And Luke and I are going to share with you what we've been doing around advanced directives for the past little bit more than a year. This has been something that we've been really focused on in our QI program, so we will go ahead and share with you what we've been doing. First, I'm going to tell you a little bit about our health center. We're an FQHC. We're in southern Sonoma County. We've been FQHC since 2000. We have about 23,000 patients at this point, and we do a little bit more than 100,000 visits annually. We do the general scope of primary care, including family medicine, medical care, women's health, OB, GYN, dental, mental health, and wellness services. We also have under our umbrella a homeless health center and 2 school-based health centers. And just to give you some context for our project, we've got about 17% of our patients are over 55 years of age. We noticed, we've been involved in the Sonoma County initiative that Dr. Moore mentioned just a couple minutes ago. And when we took a look in our medical record for how many of our patients actually had an advance directive documented on chart, and I will say that we limited this to patients over 55, so the 3% that I'm showing for May 2013 would have been much lower had we looked at just our entire patient pool. You know, we were pretty horrified and decided that this was something that we really wanted to work on. And as you can see our graph here and our ending number. Our last check on this was in August. We were at 28%, and I'm sure some of you are noticing a little bit of a data gap before this starts, and you don't see all the way down to 3%. We had a little bit of a data discrepancy in terms of how we were collecting the data, but we have it on track for quite some time now with a consistent measure. So I'm going to turn it over to Lou to start telling you about what we've done.
Hello, everyone. So I think the way we've looked at this problem is there is not any one solution. We've looked at it as multiple solutions, and both organizationally and for our individual patients. We don't expect to find one simple program or one simple form or one simple shift to our workflow. We've really looked at this comprehensively. The first thing we did back in May of last year is we essentially set the goal that 100% of our staff would actually have an advance directive on file. And we endeavored to do a training with every employee in the entire organization. So we went to each individual department and team, and we essentially trained, discussed what an advance directive is, why is it important, what can happen if one is not present, and then we actually went through the actual form. We, at the time, were using the 5 Wishes, which is a form through Aging with Dignity funded through Robert Wood Johnson Foundation. And so we just made these forms available to our entire organization and their loved ones. The goal here was also to, or the intention was to raise the comfort level across our staff in discussing end-of-life care, issues related to death and dying, and so we essentially made these forms available not just to the staff but their families as well. The teams that actually delivered this this training, that we had a physician that works primarily with our senior population, a geropsychologist who specializes in the senior and aging population, and then myself just from a programmatic and kind of project management perspective. So the 3 of us essentially went to all of our care teams, all of our various departments, including those that have low touch with patients, but we felt it was important anyway to have this training with IT, with billing, with human resources. So but really our target was those that have high touch with our patients, and specifically the clinical support staff, who often are first opening this conversation with the patients. The next thing we did was we launched a shared medical visit. When we looked at this problem, we often would see that, you know, maybe a patient would come in 3 or 4 times a year, or once a year, or even 10 times a year, but they were never coming in for this opportunity to have this conversation. It was so to have a large conversation like this with a patient that is potentially very complicated, complex, it doesn't fit neatly into the normal workflow of a family medicine office visit. So we needed to come up with a different strategy for how to give these patients the time they need to have these very important conversations, in some ways outside of the typical family medicine clinical space. So we're blessed with a few larger rooms where we can conduct shared medical visits, and we launched a weekly shared medical visit called Completing Your Advance Directive. And it's led by a provider. Each patient has a face-to-face encounter with the provider, and then really the intention is to be able to go through the entire form, to orient the patient to the importance of it, to really answer any questions, to develop a really unique, individualized advanced care directive with the help of the provider, and then essentially actually complete the form. And it may not happen in one visit. We really, there's a fine balance between wanting to make this as easy as possible on the patient to complete the form, but also wanting to make sure that it really means something to the patient. So we found some patients wanted to complete it right there, and we could do that. But we also found that some patients want to take it home and talk to their loved ones, their healthcare designee, their healthcare agent, to have those conversations with their family before they actually kind of make it official. And so we have this group as a weekly kind of open group. People certainly make appointments, and we do reminder calls for the shared medical visit, but we also, people can just drop in. So that was really the intention here, is to kind of move it out of the clinical space and give it the time that it really needs. We've seen about 250 visits through this vehicle.
So, and that, just so you have a frame of reference for that, that's about 5% or so, we think, because some of the patients required more than one visit. So we think that's probably somewhere around 5, maybe a little more than that % of our over 55-year-old patients. I want to talk a little bit about the changes that we made in the clinic, because as Luke had said, we knew that this was not going to be a one-size-fits-all kind of solution, that we really needed to accommodate the full range of patients here, those that are more likely to go to group, those that are more likely to only be with their provider. And so we wanted to really work with our care teams and see if there was any way we could help get this done as part of the visit. And, I really appreciated what Dr. Moore also said about having the conversation. So we wanted to really make having the conversation a priority for people. And so just to let you know the nitty-gritty of what we did. So we first took a look in our EMR. We have a very structured way that we review what's due for patients within our EHR as part of a huddle before each shift. And so our care teams are really used to saying, oh, they're due for this, they're due for that, and then setting an agenda for today's visit. They spoke on what the patient was coming in for and what other kinds of things come up in our alerting system. So we went ahead and we put an alert in our EHR for everybody over 55, a one-time alert saying advanced directive. And then we asked that when an advanced directive was scanned into the chart by our health information, medical records people, that they would go ahead and hit suppress alert so that we didn't keep seeing it and keep addressing it at every visit. So we went ahead and set that up, and then we did a lot of education with our clinical care teams around which buttons do we need to press to make it count as one done. So we did some education on documentation. We instituted reporting and tracking, and as you can see from our graph, that needed a little bit of time to work out, what we count as completed or advanced directive. And, what we ended up deciding was they have to have something scanned in on their chart. And we're looking for either an advanced directive or a pulse form, either one of those things, and we consider that advanced directive completed. We also collect data around the conversation, but we aren't tracking that in any kind of regular way at this point in time. The other thing that we did, and I think is worth considering even to get our baseline, is having to mine the data out of all those things that were scanned in before we were paying attention. So we started to take a look in our, scanned patient documents and try to find which ones of those were advanced directives and PULSE and complete the data entry on the back end. So we didn't put that back in the laps of the care teams, but rather just had that data entry done in health information, and then people could feel like they weren't necessarily starting from zero. And then I think lastly, we really, as Luke said, we did educate the care teams quite a bit on doing their own advanced directives. We did a lot also around how do you talk to patients, a lot of role-playing and examples on the care teams. How do we talk to patients about these things? What can we do to present these forms to patients and make them a little bit easier? So one of the things that seems really simple was, there's a lot of demographic information that needs to be filled out. Well, we can actually print that on a sticker. So trying to make it as easy as we possibly can, both on the staff and on the patient. We talked a lot about counseling, how to counsel patients on completing the form and offering the group visit, and how various members of the care team can participate in the filling out of the PULSE form as well. So those were some of the things that we did within the clinical care teams.
Yeah, and so I think we're about a year into this now, and we've started to see some progress when we have our patients in our four walls on getting their advanced directive complete. We also realize we will never get to our goal of 100% of our patients or 90% of our patients 55 and older completing this unless we actually move outside of our walls. And I think that's really where we're at now with this endeavor, is really engaging at a community level, taking this to where people live, work, go to school, where they gather. We have reached out to the County of Sonoma, St. Joseph Health System, the Petaluma Healthcare District, and potentially some others to begin to host monthly community events that are open to the public on this topic, and really do a media blitz and a campaign, and have that monthly event rotate around Petaluma. And our hope is that, again, it's more than just having the conversation once we have them captured in our health center, but really bringing the conversation to the broader community. And we think that's really the only way that this continues to trend up to the levels that we envision.
So I think it's important to talk a little bit at least around our challenges, and I think we have many challenges around doing this, and I think we've been very successful over the last year, but we struggle with a lot of the things that I'm sure those of you who are listening struggle with also. First of all, scarcity of time in PCP visits. So trying to fit yet another thing in to those visits with the PCP or care team is a real struggle. Even though as our care teams grow, we have more resources, it seems like the number of activities that we're doing during the visits is growing at a faster rate than our teams are. The length and complexity of most advanced directive forms, I think this is a really big issue that we're currently struggling with, and actually actively looking to change what forms we use, because there's a certain portion of our patient population that will go to the group and that will sit down with the 5 wishes or any other lengthy advanced directive form. And there's another portion, we'd like to make it easy enough so that they could potentially get it done as part of their PCP visit. I think that, so we're looking for something shorter, more simple, more affordable. So we're looking at that right now. And then, of course, language and culture issues always come up around these kinds of topics, and I think that's one of the things that our care teams have talked a lot about is, the difficulty, that we have really addressing these sensitive issues with people who speak other languages and are of other cultures. I think that's something that we rightly will continue to struggle with and struggle through. And
yeah, so I think that's what we have for our presentation, and we're very open to questions, and I'll pass this back over to Canel.
Great. Thank you all. Thank you guys for this presentation. So just a reminder, if anyone has questions, they can submit them through the chat function. We do have a question that's come in. So how has the ACA debate, specifically around death panels, helped or harmed the discussion around palliative care and dying with dignity? And I guess I'll add to the related question, Bob, specifically for you, from your perspective as a health plan, have you gotten any backlash or for being a health plan in this space, any pushback on that?
Right, it's a great question. So the answer is no, we have not. But I would say that because of that sort of urban myth slash, whatever, the death panel issue came up during the earlier election, it did cause us to be careful in how we message the work that we're doing, and I think that that's been a good thing. So we really try to focus on the quality issue and being really at the center of this, and always autonomy and patient decision making is what we're really striving for, is to give people information and allowing them to make decisions, and that will have a side effect of making healthcare more cost-effective, but that really the goal isn't cost-effectiveness at any cost. It really is autonomy and patient choice and selection. So I think that's been helpful in the sense that we're always thinking about making sure we're communicating this the right way, and everyone's aligned in how we're thinking about it.
Great, thanks. And a question for Danielle or Luke, could you share a little bit more detail about the group visit and what's entailed in the group visit?
Sure. So the patients are referred either through their PCP or care team, or they self-refer. We have a lot of promotional materials around the health center regarding this shared medical visit. We're using the guidelines that the AAFP put out for shared medical visit. So when the patient arrives, they're vitalized and have some time with the provider where if they need any prescriptions refilled, or need an immunization or a flu shot, or need any lab work ordered, that's addressed. And anything that happens in that regard is communicated back to the PCP. And then while that's happening, we have a kind of a health educator begin to open the conversation regarding advance directives. And then when the PCP has kind of addressed all of the face-to-face components, the provider who for this particular group is a physician assistant with a lot of experience working with the senior and elder population. She then begins the health education component of the shared medical visit, where she opens the conversation around why this is important, what can happen if an advance directive is not in place, examples of an advance directive working really well, and some of the kind of the more clinical sides of why an advance directive is important and what it actually does. And then it's a workshop after that, where people ask questions. They go through each page of the advance directive together and complete it as, mostly for most patients, they complete it kind of individually in a group setting. And then she stays after the shared medical visit is over. Oftentimes people have questions they don't want to ask in the group. These are very sensitive topics for many of us, and they may want to have some private time with the provider afterwards. They may complete it there at the group. If that's the case, it will be scanned into the record, and they will, for some of them, they'll elect or wish to make an appointment with their PCP as a follow-up to go over the form. That doesn't happen a lot, but we always make that available to them. And then some folks want to actually take the form home, and they'll either complete and execute the form at home and bring it back to us, or they'll come back perhaps another visit to the shared medical visit to complete it at that point.
Great, thanks. Bob, we have another question for you. From an incentive perspective, how long do you plan to continue to incentivize for this, and when does this really become more part of a standard practice?
Great question. I think that the incentive will probably need to evolve over time. When you have an incentive, when pay for performance, you typically start with a pay for a process, and then you might change the process up to make it a little more rigorous over time. The ultimate goal, which is something hard to put on the PCPs, is of course to have everyone who dies die the way they choose to die, and that involves not just the advance directive, but what happens in the hospital, are the documents flowing. So there's a lot of other process aspects of improving this that we need to kind of look at. We do have an aligned pay-for-performance incentive with our hospitals that are capitated and have a pay-for-performance program with us for them to also be asking about and moving towards having advanced directives on their hospitalized patients. So having aligned incentives with the hospitals will be helpful as well. So there's a chance if it becomes very successful, we might we're likely to make it not just be based on the conversation, but actually maybe look at having advanced directives as an outcome of in some way.
Okay, great, thanks. We had another question around data and getting reliable source for data and stats on this. Does anyone have recommendations for sources for cost savings, benefits, et cetera, sort of go-to places for those types of data?
Yes, this is Bob. I put the references on the slides, and you'll be sending them out, I'm sure, for those programs that I referenced in that JAMA article in the Advanced Directive in terms of some of the cost data. Hopefully that would be helpful. In terms of collecting data, I think that's a bigger issue, is how do you collect accurate data. I think that Dr. Orrin and Luke talked a bit about that, how it's not as straightforward as you might hope for. And unfortunately, since having advanced directive completed was not considered a meaningful use measure for primary care, the standards are not as good for the electronic health records as they would have been if they did select it. They had some debate. It is a measure for hospitals, but not for primary care. So, so you have to kind of build your system to collect the data in the primary care setting.
Okay, great. So for Danielle and Luke, could you speak a little bit to the advanced directive forms you're looking into, and how are you finding forms that are validated, and how are you going about that process?
Sure. So we initially in May of last year we formed an internal ad hoc committee of folks that had of a hospice nurse, a physician that's worked in hospice, and our medical director at the time. And we looked at several options and found the 5 wishes to be the most useful at that time for what we attempted to do, because we felt like it captured the patient's wishes in the most robust fashion. I would say since then we've actually, just in the last couple of months, we've launched another. We've taken another look at this. The 5 wishes we found not to be as feasible in the clinical setting because it's so long. So what we've looked at now are the California Hospital Association form and the UCSF form, which both have advantages and disadvantages. But what we really like about them is they're a little bit shorter. They still have all the really important information that's needed, and they're free. And they're also in multiple languages. So we are in the process of shifting to use one of those forms to be determined. We currently have taken it to our patient advisory board and also a sub-ad hoc patient advisory board focused just on advanced directives for this month. So we're in the process of actually updating that. And then of course we use the standard PULSE form when appropriate, and for those that don't know, that will update October 1st. So we're going through a process of informing our provider group of those updates as we update this current, our new advanced directive form. So.
Great, thanks.
This is Bob. Just one other thought on that. I agree the UCSF form is a really particularly good one. We like that a lot when I was working at Clinical A, and ultimately depends on where the person's at, which form is the best one. It's really hard to come up with one form. That's, we actually trying to follow, in NAPA, the group that is looking at the advanced directive, tried to follow the lead of respecting choices, but was not able to come up with agreement because it depends. A form being filled out in conjunction with a lawyer working on a will is different from a form from someone who's low literacy and just thinking about this that they're otherwise young and healthy, different from someone who really wants to process the various wishes, like the 5 wishes form, versus someone who knows exactly what they want and they just want to write it down. So it is hard. And then, of course, there's a couple of online options too. MyDirective.com is particularly intriguing for the online generation. So, which offers, basically it sends you a little reminder every year. It's time to update your form, and it sends you an electronic link to your agents. So that's another option to be aware of.
Great. And Luke, we just had a request. Could you just repeat the name of the 2 forms that you're referencing?
I mentioned 3. The first is the 5 wishes through Aging with Dignity. The second would be the UCSF, University of California, San Francisco form. And the third would be the California Hospital Association form.
Great, thanks.
And the UCSF one, if you put I think it's like IHA for Health is where the website is. But if you put if you write, we think of it as an easy to read form. I think we're talking about the same one. The easy to read form is how we talk about it with patients. But if you Google low literacy advanced directive, then you come up with that one. Yeah, that's right. That's the one we're using.
I would also add that one in particular is available in quite a few languages, and that's also a really helpful, helpful thing.
Great. We have another question around faith-based organizations. Are either of you working or collaborating with faith-based organizations as part of your efforts?
Great. So this is Bob. We actually in Solano County we have had conversations with the Interfaith Council and have had a few meetings with them. It's not taken off the way the other community efforts have. It's been a bit of a challenge. The Coalition for Compassionate Care of California has a specific training available for ministers and priests and other faith leaders, which has been offered in Sonoma and Yolo counties, I think, and there is some attendance. It's not as much as one would expect. I think both in Sonoma County and Napa County's efforts, they've attended some of the meetings. It is a really critical opportunity to involve them in these community efforts.
Danielle, Luke, is that something you all have collaborated with as part of this?
Not yet. I would say not yet.
Okay.
I think that's part of that community engagement conversation that's ongoing here in Southern Sonoma County, and I think that's definitely, we envision that happening. Just we're not there yet.
Okay. And going for that,
one additional.
Go ahead, Bill.
Oh, sure. I was going to say one additional note. It's particularly. There are cultural differences in sort of the way people think about advanced care planning, and I think the faith community is key to addressing some of those populations of individuals who, for cultural reasons, have a lower acceptance of advanced care planning sort of conversation. So it is a really important piece of that puzzle.
Okay, great. So, Luke and Danielle, just going back to that community engagement piece that you spoke of before, can you speak a little bit more to how that outreach has been done and how easy or difficult it was to make those connections and collaborations?
Well, it's in process. I think that for the organizations that have come to the table, I think there's a lot of mutual benefit in this. So I think there's not a lot of the challenges related to it are more bandwidth, not a lot of major obstacles. I think everyone sees the value, and it's just a matter of operationalizing it. And it's coming along. It's definitely not there yet. I think that the piece that the county has brought is they brought a lot of great outreach materials and kind of a social media strategy and press engagement. So they've been, and these conversations are still, we're not there yet, but I would say we're very optimistic about how this particular approach is going to land. So.
Great. Well, unless there are any final questions, this is a great discussion. I just wanted to thank the presenters for great presentations and some good questions that we got going. So if people could sign up, you'll see a couple questions just before you sign off. If you could just take a few seconds to answer those questions, we'd appreciate it. And thanks everyone for joining, and thanks to our presenters for a great conversation.
Thank you.
Thank you.